Welcome back to my History of Renal Medicine lecture series, in which we explore the colorful history of our understanding of one of the most important organs of the human body. In our last installment, we explored the advances in diagnostic renal medicine in the first half of the 20th century, including the invention of the electron microscope and the inception of the biopsy, ending with a tour of the monumental pioneering work done in the treatment and diagnosis of diabetic disease. I'm Matthew Tortora, and I practice diagnostic pathology in northern New Jersey, serving Cooperman-Barnabas Medical Center and Clara Moss Medical Center. This is the sixth installment in a multi-part lecture series on the history of renal medicine, which I've given to the departments of pathology, medicine, and humanities at Cooperman-Barnabas Medical Center. This is part 2 of the third lecture, entitled Needles, Nodules, Aldehydes, and Electrons, before and after Conrad Pirani. Let's get started. Before we move into the 1950s, where most of this lecture is centered, it's worth paying tribute to a few notable works from the 1940s. One of them was published by Arthur Ellis, entitled The Natural History of Bright's Disease, in which he catalogs the clinical, laboratory, and microscopic observations on 600 patients with kidney disease, 200 of which were postmortem and 400 of which were living. In an age before effective needle biopsy, this was a Herculean feat. You may recall that it took Richard Bright 12 years to elaborate on only 24 patients, all of which were postmortem 100 years earlier. Ellis's work strengthened the correlations between clinical and microscopic findings in glomerular diseases of the kidney, and led to his proposal for a classification scheme into type 1 and type 2 nephritis. So by 1942, there existed a panoply of earnest, albeit inconsistent, vague, and often inaccurate attempts at classification of renal disease, the newest of which were added by Christian, mentioned in our previous lectures, and Ellis. In Boston in 1943, Benjamin Castleman, of Castleman disease eponymy, helped further our understanding of the relationship between hypertension and vascular disease by studying the renal biopsies of 100 patients, another Herculean feat in the days of scalpel biopsies. This was coupled with a study evaluating a potential treatment for hypertensive patients. And so if one were to take inventory in 1950, along with the discoveries of post-scarlatinal renal disease and renal amyloidosis in the late 19th century, we've added minimal change disease and focal segmental glomerulosclerosis, thrombotic microangiopathy, Alport syndrome, diabetic glomerular disease, and our deepest understanding of hypertensive arterionephrosclerosis to date. We are now only moments before Dr. Pirani enters the scene, but much would happen in those brief moments. What you see before you is a still shot from the cult classic science fiction film Logan's Run, made in 1975. It holds a special place in film history because it came out right before Star Wars, and thus it represents the last best effort that old-school sci-fi movie making had to offer, using the best technology at hand, before the revolutionary advances in special effects technology in Star Wars would eclipse everything that came before it. I suggest that in 1951, in New York City, Arthur Allen would present the world with the Logan's Run of renal pathology. Arthur Allen was a pathologist at Memorial Hospital and Cornell University, and by the looks of his photo, was a dapper man. Incidentally, those in pathology may be familiar with the work of his wife, Sophie Spitz Allen, who presented a study on a type of juvenile melanoma which would become the Spitz nevus. In that year, Allen published a textbook on diseases of the kidney, the most comprehensive catalog of medical renal diseases to date, and it had lots of photographs. In its opening pages, it features a photograph of a neoprene cast of the renal vasculature, hearkening back to the artful description in Malpighi's Renibus. One can see among the tubules and the interstitium a large number of these corpuscles hanging like apples from the blood vessels which, swollen with the black liquid, look like a beautiful tree. Its earnest efforts at classifying diseases of glomeruli earns it a place of honor among the pantheon of works before it. Allen also presciently noted that diabetic glomerular disease and amyloidosis are not exclusively glomerular diseases, but suggested that the dominant role of the glomerular lesions they produce justifies reconsideration, although he concedes that the nidus of the injury is indeed vascular. It dedicates a full 98 pages to diseases of the glomeruli. Its table of contents divides glomerular diseases into diffuse, focal, and functional categories. The diffuse and focal categories are further subdivided, and you'll notice that in the focal category is the subcategory degenerative, which includes diabetic glomerular disease and amyloidosis. Now let's take a look at some of the photomicrographs. There was subacute diffuse glomerulonephritis, which looks to be some type of crescentic disease. Acute diffuse exudative glomerulonephritis, which showed inflammatory cells filling the glomerular capillary loops. Spontaneous chronic sclerosing glomerulonephritis of dog, no less. In later years, it turned out to be, well, I'm not going to lie to you. I have no idea what this is. There was acute membranous glomerulonephritis. Incidentally, the vernacular use of membranous in this glomerular lesion refers to the appearance of fibrinoid necrosis and bears no relationship to the immune-mediated lesion also called membranous glomerulonephritis in modern classifications. And here we see diabetic glomerular disease, where he emphasizes that the lesions are vascular in nature. Also note that Allen made efforts to correlate depictable gross and microscopic findings along the bottom, along with a schematic representation along the top. But just as the ink on Allen's text was drying, a startling inflection point was about to be reached. It was at this point that three things would come together to shake off the final dust particles of the pre-modern era in renal pathology and rocket us into modernity: the advent of the PAS stain, immunofluorescence microscopy, and most importantly, the needle biopsy. The PAS stain. PAS stands for periodic acid Schiff. The roots of its inception will bring us back to this quaint lab in Italy in the 19th century, where a chemist named Hugo Schiff had recently immigrated from Germany. Here he is in a much less quaint lab toward the end of his life. His work would involve a reagent created from an aniline dye we've touched upon in a previous lecture, fuchsin, whose chemical arrangement looks like this. In his lab in Italy in the 1860s, Hugo Schiff combined fuchsin with sulfuric acid to create what would be known as the Schiff reagent. And he initially used it to test for the presence of aldehydes. He wrote, rosaniline, i.e. fuchsin, sulfite, does not combine directly with aldehydes. If one shakes with any liquid aldehyde a red solution of the crystallized neutral sulfite of fuchsin, which contains leucanolene, i.e. fuchsin treated with aqueous sulfuric acid, then one obtains at once a red solution, and this color is transformed into a lighter or darker violet blue, depending on the aldehyde that's used. In less words, Schiff's reagent plus periodic acid binds with the aldehydes, producing a color on a spectrum of pink to purple, depending on the aldehyde. It wouldn't be until 1950 that scientists at the Department of Dermatology and Syphilology at the University of Pennsylvania first used the PAS stain on a histologic sample. As it turns out, the PAS stain was highly effective in highlighting the outer membranes of fungal elements. Humorously, the photos in the journal article were printed in black and white, defeating the entire purpose of the article. However, had it been published in color, it would have looked like this. The deep pink filamentous elements are the fungal hyphae. It was soon realized that the PAS stain was also highly effective at highlighting the delicate membranes of the microscopic elements of the kidney, including capillary walls and basement membrane structures, among others. Quote, "This communication presents results of a study of the kidney with the aid of an original staining method which has been previously described for the demonstration of mucin. In brief, microscopic sections are treated with an aqueous solution of periodic acid and then colored with Schiff's reagent for aldehydes. The basement membrane of the glomeruli and of the tubules are colored bright red or purple, as are the cell outlines of the smooth muscle cells of the arterioles and capillary walls. And in an instant, the thinnest structures of the kidney under the microscope were given a much greater degree of definition." PAS was found to be an excellent stain not just for kidneys, and fungus for that matter, but for almost all tissues. But in modern practice, we only use it sparingly, instead relying heavily on the H&E stain, the one we discussed in a previous lecture, for the bulk of our interpretation, while PAS is used selectively, as in medical kidney specimens. But why? Why not use PAS for everything? The answer is in this slide. This is an H&E stained slide of tumor cells. You'll notice that the dark purple stained nuclei stand out prominently. Since much of general pathology is tumor pathology, and since much of the diagnostic distinctions between tumors lies in the nuclear detail, and since hematoxylin, the H in H&E, stains the nuclei optimally, H&E won out for most tissues. By contrast, medical kidney pathology is centered around non-tumor diseases. As such, and as thus, the PAS stain, whose strength is in highlighting basement membranes and vessel walls, is optimal. If anyone would like to know what this disease represents, please feel free to reach out to me. So by the 1950s, pathologists had at their disposal the tried and true H&E stain and the PAS stain in the histologic workup of kidney specimens. But simultaneously, another modality was in its formative stages, which was called immunofluorescence. In 1940, Coons and Kaplan showed that you could highlight the presence of a cellular antigen of interest by attaching to it a complementary antibody bonded to a fluorescing agent. The two broad techniques include attaching the antibody fluorophone complex directly to antigen or indirectly through a second antibody. This technique was eventually applied to histologic sections of kidney, where it is used to highlight the presence of certain immune-mediated diseases through the lens of a special type of immunofluorescence microscope. Lastly, and most importantly, there were significant technical advances in the use of the needle biopsy. The concept of needle biopsy was not brand new. You may recall from a previous lecture that the first biopsy was performed in the 1870s with a scalpel. The first renal biopsy was performed in 1881, the first renal biopsy where the intent was to remove a small piece of tissue for a diagnostic analysis was performed in 1923. A landmark paper on needle biopsy was published in 1930. By 1939, the first large series of liver aspiration biopsies was performed. And finally, in 1951, Iverson and Brunn published aspiration biopsies of the kidney. Then, two simple improvements in the needle biopsy would change everything. The first was the needle biopsy itself. A better needle was pioneered by Jan Silverman. And second, a better technique. Up until 1952, needle biopsies of the kidney were obtained with the patient sitting up, which was ergonomically suboptimal and might be painful for the patient. But after a simple change in posture from sitting to lying face down, biopsies could be obtained with relative ease. In July of 1952, after a 5-year stint at the U.S. Army Medical Nutrition Research Laboratory, a young Conrad Pirani returned to the University of Illinois as Director of Experimental Pathology. It was at this fortuitous moment that the first small waves of these new kidney biopsies began to roll into his department, and nobody knew what to do with them. For reasons unclear to Pirani, the section of the lab that would have normally processed them was unable or unwilling to handle these small, delicate specimens. So his chairman brought him the specimens and said, "Try to make some sense of these small specimens." According to Pirani, there may have been more than a small undertone of cynicism in his mentor's voice over the idea that any useful diagnostic information would ever be obtained from these minute threads of tissue. Nonetheless, Pirani obliged. In the fall of 1955, when this episode of the iconic I Love Lucy, entitled Ricky Sells the Car, first aired, something very special was also happening. In this episode, the characters are supposed to be on a trip to California when Ricky sells their car. The Dietzes, fearing they'll be left stranded, purchase a motorcycle to get back home, and hilarity ensued. As millions of people watching this program were laughing in their living rooms, I wonder if any were aware of the enormity of what had also just happened right under their noses. Because at nearly this exact moment, the New England Journal of Medicine would publish this innocuously titled article, "Biopsy of the Kidney in the Diagnosis and Management of Renal Disease" by Conrad Pirani and others. Notwithstanding its innocuous title, this publication represents the most transformative point in the history of how we understand and treat kidney disease to date. If behind the gates of heaven lie all the answers to the disorders that afflict the kidney, I believe this article contained the blueprints to make the key to open those gates. The article catalogs the microscopical findings in an assortment of patients with kidney diseases, including amyloidosis on the left, arterionephrosclerosis on the right, pyelonephritis, lupus nephritis, crescentic diseases, changes occurring in preeclampsia, and a normal-appearing glomerulus in a previously biopsied lupus patient who had recovered. I'll hold on this image for a moment to let us all appreciate the importance of what it represents. Pirani had shown the world that the use of needle biopsy in diagnosing kidney disease was so easy, so efficient, effective, and relatively free of major complication that it could be done twice on the same living patient, only weeks apart. It was at this inflection point, with the key to the gates in hand, that all heaven would break loose in our understanding and treatment of kidney disease. Welcome to the modern era of renal medicine. Conrad Pirani would eventually relocate to New York, spending decades at Columbia University Medical Center, where he would continue to pioneer advances in renal biopsy diagnosis using light microscopy, immunofluorescence, and electron microscopy. And the story of the seismic impact that his unassuming paper would have on diagnostic renal medicine will be covered in depth in the next lecture. If you enjoyed this presentation, want to see more of the lecture series, or have questions about the history of medicine or of pathology, please feel free to contact me.